Welcome back, everyone who was here 2 weeks ago, and welcome to everybody who was not. I read through the comments in your um, evaluation, and when I tried to kind of narrow down on what sounded like most helpful to most people, I decided that it might be good to talk about comorbid conditions in autism. So meaning clearly, there are many mental health conditions that your autistic clients will be trying to manage while also being autistic. And sometimes it's important to find a rule out. So to think, is this autism or is this, let's say, social anxiety disorder? So sometimes it's one or the other, but a lot of the times we see that both disorders are present in clients that we're treating. And most of the time, what we as mental health counselors, therapists, psychologists treat ends up being the comorbid condition, but we need to be very, very aware of the autism that lays underneath that has a significant impact. I will do my best to monitor the chat. So if there are questions, I will try and keep my eye on those and try to answer them as we go. Also trying to navigate that we don't have a ton of time. So I'm trying to do my best. Okay, hold on. So I wanted to go over, I know we started talking about this a little bit last time, about autism in females or women, and really that term has been expanding because we're also becoming more aware of people of various gender identities being autistic and presenting in a very similar manner. So the terms you will also encounter in social media or the literature is nuanced autism and high masking autism. So overall, those are our clients that get missed most because they are very good at suppressing or hiding their autistic um, symptoms, which feels to people often like that will be helpful in everyday life, but our research so far on masking, what it is showing that actually it tends to do the opposite. And the more people mask, the more co-occurring mental health conditions they're often dealing with. So that is a pretty important piece to remember. I think the other tricky situation with calling it female autism, which I have done in the past, is that we are learning more and more about gender diversity in autism, and there being a lot of tricky gender situations that are not great to summarize in the term women. So what you will notice in symptoms that of people that potentially are on the autism spectrum and have been missed are often not the things we look for when we think about autism. So we often see that eye contact appears fairly typical. Sometimes if you spend time watching people's eye contact, you will notice that it might not be completely quote unquote normal. What the DSM calls this is difficulties in regulating eye contact. One thing to know is a lot of autistic people who make good eye contact are people who are constantly monitoring themselves and others and have to remind themselves to make eye contact. When you think about therapy and somebody being focused on making eye contact and suppressing various autistic mannerisms, it quickly becomes apparent that a lot of our clients who deal with this are very, very overwhelmed. So the things they are processing consciously are much more and bigger than the things neurotypical people pay attention to during social interactions. So overwhelm is very common. Overwhelm can lead to meltdowns and shutdowns, as we talked about briefly last time, but they can also lead to suicidal ideation and that can be really tricky because consistent or fairly chronic suicidal ideation is not uncommon, actually fairly common in a lot of adults with autism. This is where you need to pay attention to see diagnostically where is your brain going, because I feel a lot of us, when we work with clients who have chronic suicidal ideation and tend to not quote unquote get better, we pretty quickly often move towards a possible personality disorder. But when you treat autistic clients as if they had a personality disorder instead of autism, that often can make them worse and more dysregulated. So that is where diagnostic clarity can be really important. High social anxiety traits. I don't have exact numbers of social anxiety in autism, but it is, I would say, at least 50%, if not higher, especially in level 1 autism. So it used to be called high functioning autism or Asperger's disorder. High social anxiety is very often something that's present. The question whether or not you focus on treating social anxiety is often tricky, especially when you're also dealing with high acuity, such as self-harm or suicidal ideation. The repetitive behaviors in autistic women or nuanced population tend to be more subtle, so they're not as easy to pick up on. For women and girls, what we see a lot is a constant focus on acquiring information or learning, and that can go into very specific areas. Actually, something that I see quite a bit are people who are very interested in psychology. There are autistic individuals who become therapists and can be really good at working with the autistic population because it's easier for them to relate and to understand. But also, this interest and learning can go into all sorts of directions, and sometimes they are helpful for a person. I had a person who was very, very highly focused on the sounds different birds made, and if they had heard me say this right now, they would probably be mortified, but I know there's a term for this. But that ended up becoming their career, is working in the field with this kind of information. A lot of women and girls tend to be more creative and imaginative than boys or males. Historically, in autism, we looked at creativity and imagination. In the ADOS test that we do, there's actually a very specific task relating to being able to create a story. And for historically, we really felt that autistic people were not good at making up stories, for example, but we're learning that this can go both ways. Some people really can't do it at all, and other people are extremely imaginative and creative, sometimes to the point where you as a clinician might wonder if there is a psychotic piece that's also part of the presentation. So that is something to be aware of. It can be used really nicely for coping skills, especially if people are very artistic and like to draw. That can be a very nice mindfulness activity for them to focus on something positive that's meaningful to them and that they have to pay attention to. Friendships in the nuanced population are also a little bit more tricky to spot sometimes because, well, not the friendships, there is often not an absence of friends as we often see in more the male presentation of autism. A lot of women or girls tend to have one friend, and that one friend often is somebody who is either also on the spectrum, and that's how they can really connect on certain specific interests. But it can also be a person who is socially savvy and does very well socially and with communication. And the autistic girl or woman will sort of attach themselves to this person because they can be the leader in social situations, like going to a party, for example. They might always stay close to their friend because then the attention is on their friend and less on them. So that's a really interesting tidbit. And it's something, if you're working with autistic clients who struggle socially, you can also help them work on maybe connecting with somebody and use also this as a coping skill in social situations. We see it quite a bit that autistic adults will bring a person to certain appointments that might be their first therapy appointment with you, or that might be a doctor's appointment. But it can be really helpful to have this other person for co-regulation, but also to help with communication challenges. Okay, next, I know a question came up last time about autism and ADHD and this newer term. It's not a clinical term at this point, but ADHD, you will see that quite a bit if you're on social media learning about autism. There is a lot of, it's interesting. Autism and ADHD in some ways are polar opposites, right? Autistic people, they have routines, structure, they like things to be organized and follow through on their plans. And with ADHD, all those things can be very tricky to do. So, except for hyperfocus, that tends to also be something that a lot of autistic people are automatically doing. But ADHD tends to be, right, like executive functioning is impaired. Establishing a routine is very, very difficult, if not often impossible. They impulsively do new things or change what they're doing. So when you think about somebody who is autistic also having ADHD, when we say it's comorbid, that can be really tricky and it can be really dysregulating for a person when they say, well, I've made this plan, but I can never follow through on this plan. So by the end of the day, I'm completely dysregulated and I can't function. So those can be great things to work on in therapy with skills and structure. But again, depending on how well controlled the ADHD is, that can be very difficult. Um, the ADHD group is, so this is newly emerging, and there is not a lot of literature about this yet in the peer-reviewed literature world. But when you go on social media or you read online, you will come across this quite often. And there is a recent genetic study that was done with 3 groups. So there was a group of ADHD participants, ASD participants, and participants who had both. And they were able to identify a specific genetic chromosomal region where people fell when they had ADHD. So there is a chance, there is emerging evidence that this might be actually a subtype of autism, as I think over the next few years, after we've moved everything into autism spectrum disorder 10, 11 years ago, I think we will in 10 years again move in the opposite direction and find more subtypes of autism and hopefully find out what's most helpful for specific subgroups of autistic people. ADHD clearly is also something people can have without any autism. For me, the major differences are the sensory sensitivities. I think ADHD people also can have sensory sensitivities, but when they become prominent, to me, that signals that there is an autism piece. Also, um, the idea that a lot of ADHD people don't have necessarily these, we call them deep dives, or the special interest that really takes up most of their time. So those are some of the bigger differences. I think it can be good to know if autism plays a role in your client, because for some folks, being treated with a stimulant or other autism-related medication can make them function quite a bit better. But like with most medications and autism, that's often difficult to predict. And there are quite a few people who do not see a significant benefit from medication for ADHD. Anxiety disorders. To me, autism and anxiety go hand in hand with the population that we treat here. So it's mostly level 1 anxiety, some level 2 anxiety. And here we are again, such like with autism, I think it needs to be established whether a person has autism, whether a person has an anxiety disorder but not autism, and whether a person has autism plus an anxiety disorder. So generalized anxiety is very common. Over 40% of people are diagnosed with generalized anxiety disorder. We see it a lot in kids, that a lot of things such as needing to know how things are going to go. What's the plan? What's going to happen? What does this look like? So a lot of the more certainty people on the spectrum have about a new situation, the better they tend to function. The tricky piece is, as we all know, that our world often, unfortunately, is not nearly as predictable as we would like it to be, and that can be pretty distressing to autistic people. And we tend to work in therapy a lot on helping the person finding their own structure and communicating enough that they can get additional information, because otherwise they often shut down. How do you, your question popped up, which is nice. How do you differentiate between autism and malingering? So are you specifically talking about malingering or feeling that that they are autistic, but they're not? Or is it autistic people who malinger because they feel that they're kind of paranoid about having certain, maybe other mental health conditions? That's something I would ask. If you can pop that in the chat, that would be helpful. When we work with generalized anxiety disorder with autistic individuals, we work a lot on planning, communicating. So I had a client who was recently hospitalized. She needed a break from group. And this is an adult female in her late 30s, with significant anxiety. And I was talking to her and she said, Julia, it's impossible to take breaks from group. And I'm like, what do you mean? Did you ask? And she said, well, no, I didn't ask, but they lock all the doors and they say that everybody has to be in group. So that is what she heard very rigidly. And at that point, she did not communicate further to ask a staff and say, if I need to take a break, how can we do this? So we actually worked with the treatment team and helped my client with this little script. Like, if there is a question you have or you feel something isn't possible, please ask a staff or a nurse about this specific situation, and they will likely work out a situation with you, which is what they did. So we ended up having her make a couple cards, because when she would get really distressed and dysregulated, her communication, verbal communication is very difficult for her. So she could just hand this card to a staff and says, I need to take a break. And then she didn't have to ask anymore, and it was worked really well. And then they would unlock her room and everything was great. But this is an example of how quickly autistic people can get stuck and then not sort of think about other options that might present themselves. OCD and autism are very tricky. I feel when I look at the DSM or even the charts that are out there, they make it seem like it's really easy to sort it out, but it is not. Overall, the differences that I look for between OCD and autism is that OCD in autism tends to present as significant intrusive thoughts and compulsive behaviors that do not lead to any type of relief. So with OCD, right, one of the criteria always is it must cause distress for the person. And in autism, when a person has OCD also, they can have very distressing thoughts and images. So a lot of autistic people have very visual brains and they see the things they're thinking about. So I have several clients who get really violent, intrusive images that are really difficult for them to work with. Um, The other tricky thing is that I think all of us know that the primary, most effective treatment for OCD is exposure and response prevention, ERP. And this tends to not work nearly as well for autistic clients, which can be really frustrating for the clients. And also, I think sometimes for the providers who feel, well, I'm doing everything I'm supposed to do, but my client isn't getting better. What we work with instead of ERP is trying to distract. So if you think DBT, the distract skill, and the idea is to get the person's brain to be busy with something that's not compatible with this thought. So it could be singing along with a song, for example, or it could be playing a video game. So using ideally some of the high interest areas of your client. Oh, okay. So sorry. Using distraction is more effective, but I still feel, hold on, differentiate on using external motivational to maintain their desired lifestyle. So I think there are different opinions on this. I feel that letting people use their special interests, so let's say video gaming, right? Most of us hear video gaming and it probably pops up a little emotion in us because everything I feel we're hearing from the media and from some research is, screen time is bad and you should not spend too much time doing these things, and it causes a lot of not helpful mental health issues. With autistic people, however, if it's the right game, I always have to preface that if your client is an angry gamer, I would not send them to play the game that's making them super irritated, right? But there are a lot of games um, that are much kind of calm games. There's some of these farming games, where you're like collecting things and you're growing crops, and those can be really, there's actually some research that has been published that is showing that some of these, I call them the chill games, like very low key. There isn't any fighting or battling or winning or losing even. It's just you're creating a scene and people can create their own house or their garden or they can make friends. So those types of games are actually, when they studied it, very helpful, almost like mindfulness kind of exercises. A lot of my clients really struggle with more mainstream sort of approaches like meditation. A lot of my clients get really distressed during meditation because they get so sucked into their thoughts. And again, the idea is you practice it long enough, right, that you can separate from it. Most of my clients are not able to do that. So for them to have something else to focus on rather than trying to let their thoughts go seems to be more effective. Um, OCD behaviors, again, when we think OCD versus autism, OCD behaviors and compulsions are anxiety driven. And unfortunately, right, as we know, when you engage in those behaviors and you have OCD, your OCD tends to get worse. Autism, repetitive behaviors, and stimulatory sensory driven interests are interest based, not anxiety based. So they're often a sense of comfort and regulation for the person. Instead of with OCD, right, you do the compulsion and your anxiety comes right back to you. When autistic people engage in repetitive behaviors, and that can be, again, can be movements, right? Or it can be sensory, touching things, feeling things, fidgeting, or it can be engaging in these special interests. They actually help a person feel more calm and engaged. So that's when I look at the difference of OCD versus autism and OCD with autism, the things I try to go through in my mind that I can make an appropriate diagnosis. I do feel autistic people who have OCD, it's really important to ascertain if they're both. And if the most effective tool I find to really look at OCD symptoms is why it's called the Y box, the gosh, now I can't, obsessive behavior scale. I can send, when I send my presentation later, I'll attach a PDF of that scale. Even if you're not a diagnostician, even in a therapy session, to go through that list with a client can be really eye-opening of some of the things they're dealing with internally that we usually don't know or know how to ask clients about. So I will attach that as a document so you can look through that. Yes, Yale Brown Obsessive Compulsive Scale. Thank you. I think that is the best tool we have. It's free, so it's really easy to access. So I think that's a really nice resource to have. OCD, autism and social anxiety. I wouldn't be surprised if most of us have at least one or two clients that have a social anxiety disorder diagnosis where people have never thought to look further and deeper to make sure this isn't a symptom of their autism. Overall, I feel a person without autism who has social anxiety disorder, they're dealing with a performance deficit. They know how to do the social things. It's pretty natural for them. But when they're in a situation, they are terrified that they're doing things wrong, right? That people are looking at them. And it's not because they do not have the skill. When you think about autism and social communication difficulties, what we're actually seeing is people having a skill deficit. They don't know how to do these things. And now they're in a social situation where they don't speak the language, right? Like if I was landing, I don't know, unfortunately, even let's say in Mexico and I had to be part of a social interaction, I don't speak Spanish. I would probably feel anxious because I'm missing a lot of what's going on. And that's often what autistic individuals are experiencing in social situations. And that can be really impairing. And when you think about social anxiety disorder, what you see, the symptoms are the same things, right? They're reluctant to engage in social situations. They try to avoid them. They have extreme anxiety when they're in the situation. So all those things really overlap. And you have to dig deeper to see, are there other components for this client that would lead us to think that they're also on the autism spectrum? Therapeutically, again, we work a lot with scripts and other supports. So if the person has a friend who is socially not anxious, stay by your friend. That can work really well for people. Or if you have some scripts. A lot of spectrum people really like scripts. So the idea is that they practice ahead of time of what they're going to say. The tricky thing is that you can't ever predict how the social interaction is really going to go, right? Beyond sort of the introducing yourself and saying hi and I like these things. After that, I feel social communication can go almost any way, and it's hard to prepare our clients for that. So sometimes it's also working on some. I'm very torn about the distress tolerance skill in DBT. I feel the way it's often used is maybe not really helpful, but also in a social situation, a person can avoid thinking that, okay, this is going to last 30 minutes, then you're going to be done. What are you going to do to kind of come down, regulate, so the person can sort of see past the piece that they have to accomplish? I mean, this can be as similar as having to make a phone call. Phone calls and spectrum people are really often at odds with each other. A lot of spectrum people really, they do observe a lot of what's going on and they do gather information. And when you're on the phone, you don't have any of that information. So especially people who are nervous and worried that they're going to upset somebody, they tend to be dialed in on watching for any signs of possible upset, and they feel it's their job to not make the other person upset. And on the phone, you're missing a ton of that information. So that's often where we're also working on sort of real life adaptive skills, right? As an adult, I mean, there's more now with email that really we can accomplish. There's a lot of text options, even though there's the other part of autistic people who hate to text because they have no context. So those are things when you think about communication and anxiety in social situations, there's a lot of stuff you can work on in therapy that aren't going to fix the anxiety, but that can teach some skills that can make social interactions more manageable for the person. Mood disorders. Let me put them all. Whoop. So co-occurring mood disorders. I think often it feels like, well, clearly a person who has depressive disorder, they don't necessarily have autism, right? But what if you get a person as a client, they come to your office and maybe the heads up information says this person has major depressive disorder, and now you're finding out they're not leaving the house, they're not talking to anyone. You watch them, their eye contact is poor, they're kind of slouched over, they're talking in a monotone voice, they're hard to engage. Those could all be symptoms of major depression, right? A person is really, really depressed and they can't engage, they have no energy. But also, those are symptoms that all of those could be described in a person that's on the spectrum. And I'm not saying that you need to screen every person who comes in and is depressed for autism, but when there is overlap with where you're seeing less engagement, you're seeing less eye contact, socially very disengaged, it is something to think about. When you're working with teenagers or kids, this is interesting because autism and depression can look the same and it might be their first depressive episode. So how do you think to sort of rule out is this autism? The biggest piece with depression that can look like autism is before the person got depressed, how did they look then? So you will have some kids, autistic kids or they've never made eye contact. They've always been pretty socially isolated. They've never talked much. And that preceded their depression, then you really need to look for autism. If the person and the parents say, my kid's always been really engaged, we've never had social issues, and suddenly in 8th grade, they've just fallen into the black pit of despair, then you're more likely looking at this is major depression, the way this person is presenting. Sometimes getting that information can be tricky, and with adults, so you will, again, with very aware, self-aware individuals, they will tell you, they say, I am depressed and I think I have autism. Don't dismiss it. I think when somebody says this, you need to do something to at least look into it. And if you don't feel comfortable doing that, then having a referral source when you can say, there's a person I know that you can talk to maybe get a better answer, then that's also a very appropriate thing to do. So that's depression rates are very high in autism. We see them starting to spike with middle school age. So 5th, 6th, 7th grade is where often I say the kids that used to be loud and annoying and all over the place, suddenly they start pulling back. And that it's really sad to see when I work with kids who are, I used to see them for being impulsive and having meltdowns, but suddenly you see this detachment from everything and hopelessness. High suicidal ideation. I think we mentioned that last time. Suicidal ideation is very high in autistic population. They have found that they studied a cohort of 8-year-old boys with autism, and 33% of them had made suicidal comments. So that's little kids, 2nd grade, and they're having these thoughts. And you need to be really aware. The other piece to be aware of was suicidal thoughts and communication of suicidal feelings is that for some people with autism, if they're in meltdown mode and they are communicating, they might say things like, I want to kill you, I want to kill myself. And you need to be aware that that's in the context of a meltdown. I'm not saying you shouldn't pay attention to this and evaluate it further, but it is a common way for autistic people to say, I don't know what to do, I'm at the end of my rope, I need help. So sometimes we work on communication. When you're saying, I want to die or I want to kill myself, what are some other sentences, statements that could help other people better knowing what you need. I just got referred a college student who was at a university back east, never had any kind of aggression, never lashed out, was in a situation with a roommate who played his music all night long, and he needed quiet to be able to sleep, so he wasn't sleeping for weeks. And he told his therapist, I want to kill my roommate. So what did the university do? And nobody said, okay, let's look at this, let's see what's going on. But what happened is that he got disenrolled from all of his classes the next day. There was a protective order that he wasn't allowed to set any foot on campus, and he needed to be disenrolled. And they were considering to maybe re-enroll him if there is a risk assessment that was completed. And there's a comment about working in the schools. Yes, these kinds of statements and comments are really tricky. And some of them, that is their go-to, how they communicate when they are falling apart. And I think often as a therapist, when you know your client, I think you tend to have a pretty good sense of what this communication is. There are a lot of autistic people who are suicidal and want to kill themselves, but quite a few, especially of the kids and teens, when this is coming out in a burst
What?
of um, it is not a threat, it is a communication of distress. So yes, very tricky. The other number that I feel is important to share, that we know that individuals with autism are 8 times more likely to die by suicide than neurotypical population. So when taken or put on commitment with autism, what's the hospital train? What, if any? I feel training people, whether it's training people in the schools or training people in inpatient settings, I think there needs to be a lot of education done for everybody, because adults and kids with autism, they are everywhere and they're not going to go everywhere. So bipolar 1, I don't have the numbers, there is a little bit higher likelihood of bipolar 1 in individuals with autism than the neurotypical population. But it is not a significant, it's not very common to have bipolar 1, even bipolar 2. I see quite a few people that were diagnosed with bipolar 2. So the idea that there are swings between hypomania and depression. And when you do a good interview and get more information, often what I find is the person says, no, I don't think I have bipolar. But our house, it would be this huge Lego set came out last week. I've been looking forward to it for the last 6 months. I bought it the day of, and yes, I did not sleep for 3 days because I kept working on that project. That's autism. That's not a mood. This is like there is something that happened, or that what you will see even more is a video game got released, and now the person is sucked into this for the next 2 or 3 days. That's not hypomania, that's autism and a specific interest. So with a hypomania, what we would see is you would see periods where suddenly out of nowhere, right, this person is elevated. With autism, when you talk to your clients, they will usually give you a perfect description of something that makes a lot of sense. And then, they've gamed out, they are done, they haven't slept for 3 nights, and now they're going to crash and they're going to feel pretty crappy. So that, again, that's not bipolar 2, and that needs to be, I feel, when you really get the information, what's really happening and what's starting an episode like this, it's often pretty clear that it's not a cyclic mood disorder, but it's part of the autism. Now, when it is there, and I do have a couple of clients who have bipolar 2, and really that's something we figured out over years of working together, where we were like, dang, right now, the way you're talking right now, I've never heard you talk about. And you can also see it as a therapist if you know your clients well. And then an additional diagnosis is warranted because it might need to be treated medically, especially if suicidal ideation becomes part of the downswing. I also have a client who has bipolar 2 and who is very good at saying, right now, I feel elevated, I feel really antsy, I feel like I need to move all the time. And for her, it's interesting because the bipolar piece doesn't seem to be that, the swings don't seem to be that big, but they're very sensitive to the swings. Again, think about autistic wanting everything to be the same every day. And now you have a mood disorder that's making you wake up different on an ongoing basis. And even just, it's not, I feel that the bipolar is that extreme, but the effects on the person are extreme. So we've been working with the med provider for months, trying to find a place to get as much regulated emotional state as possible. But again, therapeutically, what I work on with that client is finding ways to expect there to be a mood change, and how are you going to respond to the mood change. When you're feeling antsy, what's something you need to do? So she doesn't sit there and now she feels antsy and she can't really think of how to manage it. So that's therapy-wise a lot of what we work on. Any ideas working with parents of adult children with autism who are looking for ways to help their autistic children engage in treatment? So this is a really, really good question. I would say probably 25 to 30% of our clients here are young adults. And young adults with autism, I mean, all young adults until 25, right? You're kind of still navigating teenage situations a lot of the time. Autism, development, they always feel development tends to be a little bit behind. But it's tricky. Now your client's 18. They should be coming and seeing you weekly, but they say, I don't want to, but let's say they're depressed. I don't want to deal with this. It's not going to work anyway. You will probably hear a lot of comments. I've tried this and it doesn't work. I encourage you to keep digging, keep trying to find new things. I think there is value in pushing a little bit more against a person saying this isn't working. But I also feel sometimes therapists push so much, like, no, meditation really is a good thing. And the person is like, but it doesn't work. Listen to your client's feedback. You know what? If you work with them for a couple of years, you get to know them really, really well. Sometimes I'm able to slip it back in and say, maybe we should try this again. But this is one of the treatment pitfalls I find for us as therapists, is that we know what's good and we know all the evidence-based stuff. Often the evidence-based stuff doesn't work with our autistic clients, and part of it may be because they have decided it's not going to work. So working with parents, we have actually a parent support group that a lot of parents of, spectrum teens and young adults attend, because there's so much overlap. This is a really common situation. And also, I think getting the parents support. We have a therapist who specializes in just working with parents of autistic kids, and she has an autistic child, to sort of also have the parents with that frustration, because I feel you see the path to getting better, and these kids, you can't make them do anything, right? Again, I don't know how much you can make neurotypical kids do things, but these kids, when you think about, you can lead a horse to water and you can't make him drink, I'm like, you can't even lead these horses to water. Your job as a therapist becomes finding a way, corralling them, so maybe sometime they choose to go to the water, and then maybe you can figure out how they're going to drink. But I think there's another comment. I think you should all be able to see the comment, but the comment about kids because they can't even express the emotions well. It's sad how scared they are because they don't know or understand what's happening to them. So I didn't have a slide about this, but there is the idea of alexithymia, right? Inability to understand and label your own emotions. That's a tricky thing when you have these kids, teens, adults with big emotions, right? And then often there's a consequence, and the kids are like, I don't even know what happened, but now I've lost all the things I like to do because they see their rewards. And the kid is left feeling pretty terrible about themselves. So that's where often, or we can bring the water to them, I like that. But so working, and I feel there's all these curricula that supposed to help with identification of emotion. We usually, there's all these pictures, and it's really trying to find a way to engage your client with wanting to learn this. My son got really depressed. We had no idea, because he always kind of looks the same, and suddenly in a pediatrics appointments comes out that he's had suicidal thoughts. And he's like, but I didn't know I was depressed. I still don't know what that means. And he was 12 and he's really bright, right? We're not talking about kids that are struggling overall with communication. So really, I feel that therapeutically, what we really try to focus in is really developing a very safe relationship. Because I think a lot of these kids also get closed off because they know that when I melt down, I do bad things and I'm a bad person. That internalized sort of um, list of things is really tricky. And that's where you need to inquire and talk with parents. Like, is there sometimes after a person has a meltdown, they become suicidal? And that's not because you're mad at them. That is because they can't do anything about the meltdown. And they feel terrible and they don't want to do it, but now they kicked a hole in the wall and they feel awful. And there's often suicidal ideation that slips in through that. So that's when really having good plans for how to deal with a meltdown is really important so the kid knows what's going to happen. And I really am a strong advocate for not consequencing meltdowns. So when you look at research on consequences, anybody aware of what that says? When are they effective and when are they not effective? So consequences are effective if you've made a plan to go do something bad. When you're impulsive and something happens, you're not thinking about the consequence. So then having a consequence because you just had a meltdown and were super distressed is like a double punishment almost for the kids. So we don't punish it. In fact, if the kids have a good go-to, like my son really liked, he played Minecraft. And that was really settling for him. And even when he was little, he would say, well, Mom, why would you take the thing away that helps me feel calm and helps me come back to feeling better? And I thought, you're right, because we feel we're going to reinforce the meltdown, right? That's the behavioral approach. If I let you go be on the computer after you had a meltdown, that means that the likelihood of meltdowns is going to be more. It's not what we see when we teach kids how to regulate themselves and let them have access to those things. Meltdowns actually decrease because they tend to stay more regulated in general. So it's something to think about. Again, something probably that would take extra time to really get into. DMDD, I was new with the DSM-5. So be careful. It's one of those, I feel it gets diagnosed a lot in kids who have meltdowns or who are explosive. But I want you to really, if you diagnose that, really look at the DSM criteria because really it's not really meltdowns. So be careful. I just think it's sort of this catch-all that it's sometimes becoming for the kids that are really hard. And there's actually very specific criteria in the DSM for that diagnosis. Trauma. Okay, 8 minutes. Trauma, much more common in autism than the neurotypical population. Um, First, you want to consider sources of trauma. Mini case study, what if you have a very sensitive autistic girl that has a ton of anxiety, she's depressed, and she has meltdowns when she gets overwhelmed. And she needs a lot of time to herself. She needs a lot of free, do what you need to do, go draw, play. What's one of this games here? Adopt Me is one of the big games on Roblox, if you guys have heard about it. I don't know. But now couple that with a dad or a mom who's also autistic, but they are more kind of type A, like everything needs to be on schedule, everything is planned exactly, and there is no time for a sensitive girl to need extra time or to need some extra, cuddling or regulation with the parent. So you get these two, I think 20, 30 years ago, we called it mismatch in temperament, right? Like that's what we would see. And it's always been something to keep a close eye on. But I think in autism, can see that pretty extremely because you can have a really, really rigid parent who needs, I had a parent who needed their daughter who was 10 at the time. So if she didn't get 10,000 steps in, then she needed to walk around the block at night until she got it before she could come in and do whatever the relaxing thing was. And the girl hated walking, she hated running, but the parent couldn't be flexible and find maybe something else for her if exercise is important. right? And you get really rigid situations where parents need their kid to be a certain way and their kid is the total opposite of who they are. And that takes a lot of extra work, and that takes a lot of work also with the parent. So that's where I do a lot more. I might see the actual client for 30 minutes and the parent for 20 minutes. Like I feel there's a lot of work that needs to be done behind the scene to work with a parent. For us or adult therapists, think about relationships, right? Like if they're a lot of the time neurodivergent people find each other. Actually, there isn't data on this yet. I think it actually has a higher chance of success for relationships because people kind of get each other more, but you also get people that are the opposite of each other. And it takes a lot of flexibility, a lot of communication, which all of those can be really difficult. So interpersonal relationships can be traumatic pretty quickly. Um, Treatment trauma, unfortunately, is very real for this population. I have several, now a teenage client who were admitted to Huntsman 10 years ago, and we're still reprocessing the things that happened. And if I ever have to go back, I have to kill myself. I mean, to that extent that people are really sorry. How do you do? Give me a little bit more, Heidi, about how do you do that? Um, so when you have clients that need to be medical trauma and autism, I think part of it is planning ahead, like psychiatric admissions. I actually have to say Aspen Grove, I got to give two huge thumbs up. We just had an admission recently, and it started off a little bit rocky. And my client communicated to me. I was able to communicate with the treatment team, and it made a huge difference. And I saw her today, and she said, "You know, it was the first time I felt somebody really wanted to understand me and listen to my needs." So I think planning ahead, medical stuff also is really hard, and some of these folks have a lot of medical issues also going on. Suicide, commitment for suicide. Again, if one of your clients is getting admitted to a hospital, the more you can try and talk with the treatment team, the better. Oh, started not suicidal, but had a meltdown. There's so many good questions. The more you can talk with the treatment team, unfortunately, I used to send everybody up to Huntsman because that's where I was trained. I loved it. It has gotten so big that I feel all of this personal touch we've completely lost up there. So it's a little tricky. I don't know. And I didn't get paid by Aspen Grove to talk about this, but it felt perfect. Like the way we could from admission to the end, we were involved. So that was really helpful. When a person is having a meltdown and they're making suicidal comments, they should not be admitted to the hospital. Just like when a person in your office says, "I feel like killing myself," you shouldn't send them to the hospital, right? Then you ask more questions. You need to figure out what's really going on. I'm really upfront with my clients because they are really worried. If I tell you where are we at? 3 minutes. If they tell, again, the ideation is very, very common. And people are very scared that if they tell you the ideation, you're going to make the snap judgment and send them to the hospital. So at the beginning of treatment, I say, when you tell me you have suicidal thoughts, I will not admit you to the hospital. For me, the criteria are cannot contract to be safe. A lot of autistic people, again, I'm very rule following. Some of my most suicidal clients, they let me know. They let me know when they're suicidal. We have a very clear plan in the session. And if they tell you, "I commit to be safe to see you," maybe you see them a second time that week if it's possible, right? If you have people making that commitment to you and you have a relationship with your client, base your decisions on that, not on something being said as part of a meltdown or when somebody's really upset, because these admissions can be really traumatic for your clients. And again, we're working and finding better options. But either way, nobody wants to be admitted to, well, I shouldn't say nobody. There is a subgroup of clients. I can tell you that even though I have clients who've had 18 admissions to the hospital, that is the last place where they want to be. And when we say you have to be admitted, like they're saying, "Well, I'm going to walk in front of a car outside of the building, but then I have to initiate an admission." But plan it ahead, make a good plan with your client, and ideally talk with the providers where they're going to go. If you don't, one more thing, and then I'll be done. If you don't have a personal connection to where they're going to go, if they're going to an ED or up to Huntsman, what I've also done is I've written up a crisis note with a really brief summary of what my client needs and what they don't need. So then they can hand it over to the person assessing them, and then you can have some input without having a direct communication. So I know everybody's got to get to their next appointments. Thank you all for being here. And, we could do this again if there's more interest in specifics information about this, because I know this is kind of the real speed run of autism. But I appreciate you all being here, and I hope you have a good rest of your day. Thank you.
Thank you for joining us. Did anyone have any other quick question for Julia? You can either use the chat or just unmute and go ahead and ask.
And I'll drop my email here too, just in case.
Please do.
Well, thank you all for
Julia,
being here.
sorry.
Oh, yeah.
Hi. Hi, Mighty. I was talking to you new in working with the population, but I have a gal who, long before she ever got to me, um, a well-meaning family member thought she was suicidal, got pulled into an office with the family there. They said when she calmed down, she could leave. Everybody but her, then took her to the hospital where she was held down. This was the first instant where we have the medical trauma. And then it continues. So trusting therapists, like I've been
Uh-huh.
with her for 2 years. It has been very tricky, like getting her to do an OQ and even talk about suicide. Nope, she just wants to get a medical form where she has an absolute guarantee. We've now got to a point where we can start to kind of dip our toes in the water. But there's not a lot of things that make it really, like, I don't have a lot that makes it helpful on where to go with this. It's kind of just been trial and error. So any help
Mhm.
you might have or suggestions?
I think trial and error is a lot of what we do. And when you say 2 years, right, I'm like, okay, you're starting to get to know this person, right? There's also a long period of really getting to know the
Oh yeah,
person.
she's come a long way in the fact she fired me every appointment for the first 2 months, but kept coming back. And then when I had to cancel on her unexpectedly, she lashed out, but we were able to calm it down. But her lashing out has decreased significantly. Her relationship with her mom's improved significantly. Her ability, like me and her, like I can kind of be like, nope, we're not doing that. And she can pull it back and does really well. But like I said, it's taken almost 2 years to get there.
It's long-term work. And how old is she now?
She is in her 20s,
Okay.
early to mid 20s. And when this happened, she was in college and she dropped out of college and she was studying psychology.
Yeah, it's kind of one of those constellations. And it's really when that kind of trauma, and that's why I'm trying to educate therapists, like, how can we make it the least traumatic? You cannot like coax people and lie to them. That is something I have several of my clients who, where the parents said, oh, we're just going to go get some food. And then they took them to the intake. It was somebody who lived in Park City. He's now 19. That was when he was 8. And still, he will say, every time I've drive down Parley's Canyon, I get huge anxiety, especially if I'm not the one driving, and I almost panic that they might take me back, even
Yeah,
though there's no
when
reason.
she came in, I went out to get her. She's filling out a form. And she's like, I can't do this, and tossed the form and went in the bathroom. And I had to coax her out of the bathroom to my office. And that's how we started. And then
The
just like
other
one
thing
step at
that
a
we
time.
didn't talk about that could be a whole other thing is talking about the pathological demand avoidance, because you get some kids that are super reactive with that. And sometimes it's not even the trauma, it's just somebody's telling me to do something and they explode. But I would say keep going slow. What I try and do is I try and make it very clear, like I want you to know when I would feel like I need to admit you. And even then, I wouldn't lie to you. I would talk
Oh,
about it with you.
we couldn't even get to a conversation about suicide without her. Like, we're talking like the hands on the
Oh.
side where she's tapping, because there it wasn't just one, and she's gone through like 17 therapists. So like girlfriend's been around the
Oh.
block. And she's got to a point where her family, basically she's told them, you're not going to hospitalize me because hospitalizing me isn't going to work. So, like I said, we've got to the point where she's on meds. Um, she's consistent. She doesn't really miss. I've been able to put her in an anxiety group online, and I've been able to put her in a DBT group online just to get her exposed to some of the skills because I can't do it all. But
Yeah,
then the
and we
other
do have
piece,
an adult mental health group right now that she could fit in. So it's kind of people who deal with chronic depression, anxiety that's pretty severe. And that's virtual and in person. So that could be another. I do think sometimes meeting other people that aren't the therapist could be helpful.
yes.
But this is where I work with my therapist, and sometimes they're like, I feel like I'm not doing therapy. We're just hanging out because we can't talk about anything. Okay, then think about Rogers and his type of therapy, which is all about the relationship. You don't talk about problems, but you are safe and you're always safe. And that actually is more healing. None of us are taught that anymore, right? Because it's not evidence-based. But really, what we see is we see huge improvement just when there is that safe place with a safe person. And then I would try with some of my folks every now and then a very gently nudge to see if we can get a little bit, or if we're still, nope, can't go there. And then I just pull back and kind of slow down. But it is really long-term, really slow work, which I think still can be super rewarding when you see progress. But
Yeah.
also it feels like I know all this therapy stuff and I can't use any of it because the person doesn't let me get close to it.
Well, and part of the problem is when you're looking at community mental health, which isn't really, I mean, you have a lot, you learn a lot, and you learn it fast, but not a lot of like stuff with autism.
Yeah, and I have done previously, I've done a peer supervision group and we met monthly just to kind of, because some of this, I feel you need to just talk with other providers who are seeing, because these are patterns that you see with autism, they repeat themselves, right? So that can be another piece, because I do think sometimes we feel like I'm not making any progress. But you see it when you cancel a session, right? And the person's like, wait, what? No, you can't do that. I need my time with you. And sometimes I'm like, I think we as therapists also need to lean into that and say, we're doing something, even if it's not the way we were trained to do or the way it would seem to be effective. Because I know sometimes we feel like we're just stuck.
Yeah, so you're good if I email you, and do you
Yeah,
have
shoot
some
me an email.
resources you might be able to help me with? Because the other thing that this has really brought up for me that I started thinking about is because I have two that are really um just a lot a lot. Um, but both of them have had instances with commitment to a hospital and a 72-hour hold for suicide. And both of them reported really crappy experiences where, as you listen to it and just what I've started to know, it's like, well, we're making the trauma worse.
Yes, absolutely.
And I
That's why we're
wonder,
working, finding a place where autism is part of a specialty psychiatrically, which is something Aspen Grove might be open to. I think that's where we would have some answers, right? Like, because even the
well,
crisis center, they're great and they have all the things, but my clients are terrified of going there because it feels awful to them.
or they go to the hospital and they feel like they're getting pinned down and things aren't getting explained. And then you've got previous trauma on top of that. So that's where I'm wondering if there can't be, or if there isn't a gap where maybe there could be some work done in educating hospitals and, the hold centers, as
Yeah,
well as
yeah.
doctors. Like, are we asking the right questions of, are we making this worse?
Yeah, I've been trying to set up a consultation with the folks over at the crisis center, and there's just not a lot of interest. but I'll keep doing it because you're right. My clients that have the need to have a safe place to go sometimes they're terrified of going. And then I feel it takes us a month to kind of get back to where we were before the hospitalization because the trauma has increased. So let's connect, Heidi. I like your thinking. Shoot me an email. I do have to run.
I'm going to send it right now. And yes, I would love to, because I think sometimes you don't know there's a disconnection in services until you kind of get thrown in it.
Well,
So
because we're getting all these new services and they're awesome, but people need to learn the stuff because you have to do it differently. That's where we're at. So, all right, thank you. I'm passionate about this kind of stuff, so I get a little animated, but I appreciate you all and have a good rest of your day. And then Heidi, I'll look for your email,
Julie,
okay?
I just sent the email and I just said, this is Heidi. Did it come through?
Okay, perfect.
Okay. And then I'll send you my personal one or my cell if you need that as well. So
Okay, sounds good. Thanks, Heidi.
fabulous. Thank you.
Thanks, Joseph. Bye.
Bye.
Thanks, everyone. Enjoy the rest of your week.